Good afternoon. My name is Leif Haase. I direct the California program of the New America Foundation. Now, on behalf of the Foundation, I'm delighted to welcome you to the rollout of the recommendations guided by the work of the California Task Force on Affordable Care. 80 years ago, the first Blue Ribbon Task Force to study the rising costs of medical care observed with some astonishment that the cost of care had risen to 4% of national income, or about $30 per American annually. The members of this 1930 commission also noted that everything seems to point to expansion rather than contraction in the volume and complexity of care demanded by the people of the United States. They were right. Through a combination of conscious decisions and historical accident, the U.S. has built a $2.6 trillion healthcare system with almost $250 billion a year now spent in California. This trend of rising medical costs places an increasing and unsupportable burden on the budgets of California's families, businesses, and the state. With the support of the Blue Shield of California Foundation and in anticipation of federal health reform, New America was honored to convene a group of the state's leading healthcare stakeholders and experts. Over a year of conversations, as you've seen in the video, we explored what could be done to bend the cost curve in immediate and practical ways and to get better value for what we spend on health. The discussions of this high-level group were guided by two main principles. First, that there's a large body of evidence that we get relatively poor value for our health care spending if outcomes for patients are the right measure of success. Our system focuses on treating illness rather than promoting health. Any sustained effort to improve the value of health spending must turn this focus on its head. Second, California has a long history of integrated and coordinated care practiced by insurers, hospitals, and medical groups. There are tremendous lessons and opportunities from the daily practice of medicine in California for reining in costs while preserving and indeed increasing access to and quality of care. The report that we're releasing today was guided by these principles and by the deliberations of this very engaged group. Before we turn to their representatives on the panel and to our distinguished guests, I'd like to make a couple of very brief observations. First, in the wake of federal health reform, these findings are even more salient and urgent. As in Massachusetts, which enacted universal coverage in 2006 and continues to grapple with spending, the promise of sustained affordable coverage in California depends largely on our making headway in bringing down costs, especially in a period of tight budgets and social needs that include and go beyond health services. Getting the maximum value for each dollar of health spending is both an economic and a moral imperative. Federal reform contains many of the seeds for controlling health costs, from new centers for innovation and cost effectiveness, pilot programs for bundled care, and greater support for prevention and primary care, but its success in this regard depends principally on state and local actions. As Dr. Atul Gawande has put it, one truly scary thing about health reform, far from being a government takeover, it counts on local communities and clinicians for success. With its history of managed and coordinated care, California is well positioned to capitalize on the incentives contained in federal legislation. However, these advantages are not set in stone. Indeed, by some measures, the capitated and delegated model of delivery that has kept down spending in California in the past is in retreat. Second, getting better value for health spending relies on a variety of actions. These range from individuals taking responsibility for their own health to adopting sensible new laws and regulations to companies taking bold steps in the private marketplace. There's no magic bullet for bringing down health care costs, but a number of coordinated steps instead, which we'll take up in detail in the discussion today. Likewise, we hope that this report helps to broaden the coalitions we need to build that will make getting better value for health spending a reality. It's not the end of a process, but the beginning. The report includes recommendations on which action can be taken right now and in the near future to control the rise in medical costs. We've been fortunate to have in California a large group of forward-looking healthcare leaders who are committed to this goal. Our aim is to expand their circle and their influence. It was an enormous privilege and pleasure for me personally to serve as the executive director of this task force and to learn from these leaders, many of whom are on the panel in the audience today. It would be just literally to call out the complete roll of attendees to acknowledge our debts, but I want to single out a few individuals and organizations. From the task force, Daniel Herlinger of AARP is here, as there will be Lisa Folberg from the California Medical Association. We're joined by leaders from the California Healthcare Foundation, Health Access California, the California Association of Physician Groups, the California Hospital Association, and the Latino Coalition for a Healthy California, among many others. All of you have done so much to shape what we know and think about our state's healthcare system and how to improve it. And the task force, in many ways, was the result of the vision of former CEO of Blue Shield of California, Crystal Haling, her colleagues Virginia Witt and Richard Thomason, who are here today, and Brenda Solorzano. I want to single out particularly as well the extraordinary work of Micah Weinberg, the staff director of the task force, who's the principal author of the report and will moderate today's conversation. Also my New America colleagues, Claudia Bustamante and Liz Wu, and Carrie Cummings and Stephanie Yoder from Ziegler Associates, who put together today's program. One of our most important healthcare leaders, both in California and nationally, is the Secretary of California's Health and Human Services Agency, Kim Belshé. On behalf of New America, I'm delighted to welcome her here today. She has served as Secretary since November 2003, managing a staff of 32,000 employees, 12 departments, and 1 board that are responsible for providing Californians with health, developmental, mental, and social, and other critical services. She previously served for over a decade in leadership positions in state government and in California foundations, and holds degrees from Princeton and Harvard universities. We know from recent comments by Governor Schwarzenegger that federal law will be live on arrival. With that in mind, as her reward, Kim gets to scale the mountain one more time as the point person for implementing federal reform. Please welcome Kim Belshé.
Scaling mountains. I'm glad I'm tall. Well, thank you all for including me and for the opportunity to join a very distinguished group of panelists and members of the task force, which when I looked at the list, I said, these really are the healthcare policy and provider glitterati of the state of California. And congratulations to New America for pulling them together. I appreciate the time to come and talk with you this afternoon a little bit about Governor Schwarzenegger's priorities and thoughts regarding implementation of health reform and opportunities we see to bend the cost curve and to bring better value for our residents in terms of healthcare spending. This conversation is timely and relevant, and we all know there's lots of meetings we go to and reports that are issued that kind of go off to a shelf to be reviewed at some future date, but there really couldn't be a better time for the task force recommendations to be coming forward. And really, there's an exciting chance, I think, working together for us to advance some long overdue reforms to our system of how we organize, deliver, and pay for medical care. We come together, just about 1 month since, over 1 month since health reform was enacted. And I think all of us in this room have learned a great deal over the course of the past 4 or 5 weeks about what health reform is all about. How many people have read all 2,700 pages? Okay, I see a couple hands. It actually was a serious question. So we've all learned a lot, especially those of you who have waded through the 2,700 pages. Come and see me afterwards. I could use a briefing. Because we're still wading through the bill. And one of my points here is that, yes, there's a lot we know, but there's a lot still that we don't know. And I worry, in fact, that we don't know what we don't know. And so we're making progress in terms of working through this, as you all are as well. But we need to acknowledge that there's a lot more work to be done. There's a lot of federal guidance and regulatory direction that's going to be required. And I know for some that gives them some pause in terms of the idea of moving forward with a fair amount of dispatch in terms of implementation. But what I want to talk about is why I think we really do have a responsibility to move forward and to move forward thoughtfully and responsibly, because certainly there's a lot we don't know. But there are a lot of things we do know that matter and inform our shared understanding of what we need to do and where we ought to focus. To begin, we know that implementation does matter. For over a year, all the discussion really has been focused in Washington, D.C. in terms of policy development, dialogue, deliberation. Now the attention is shifting to the states, because responsibility for implementation, as we know, rests with the states. And so state leaders recognize how high the stakes are relative to the responsibilities that we now bear in terms of moving forward with this wonderful, brave, exciting, scary thing called comprehensive health reform. And state health leaders are also, and governors are also mindful that a lot of these implementation issues that are so critical, frankly, weren't all that well tended to, I would submit, in the context of actually developing the federal law and talking about and deliberating the federal law. So the success of reform, really, it's about us. It's about the people in this room. It's up to us to see whether or not California can really step up and deliver in terms of the promise of comprehensive reform as it relates to coverage, affordability, and improved health outcomes. So the decisions we as a state make in terms of implementation are very, very consequential and will have far-reaching implications and require very careful and thoughtful deliberation. And I think this task force is well positioned and well suited to really bring important voice to many of the important implementation matters that will come before our state elected leaders and our policy administrators. We also know that leadership matters. States have to be ready to step up and to act, and governors have to be ready to lead. And yet we see around the country any number of examples of governors who frankly aren't all that excited about health reform, who aren't seizing the opportunity to execute the new responsibilities required of state governments. Governor Schwarzenegger is an unusual Republican governor. He's a Republican, also the largest state in the union, and he spoke last week to his commitment to step up and to lead, to not step back from reform. And he was very clear that he sees it as his responsibility to make sure that our state is as prepared as possible to responsibly implement the new reforms. And he articulated his willingness to roll up his sleeves, work with the federal government, with our state legislatures, stakeholders, and others to get the job done and to get the job done responsibly. And I would submit whether a governor is in his first term or last term, her first month or her last month, executive leadership matters and is consequential to how these implementation responsibilities will move forward and how well executed they will be. We also know that experience matters. California is not starting from scratch as we move forward with this wonderful thing and stressful thing called comprehensive reform. We made a good run at it in 2007. And notwithstanding the setback in January of 2008, I think our state's effort made an important contribution to our state's understanding, policymakers' understanding, program administrators' understanding of what it takes to think about and integrate the essential elements of reform. We also, I think our contribution really helped to inform a lot of the policy development and the ultimate framework that is now the federal law of the land. So we're not entering into this implementation challenge for the first time. We are not thinking about how to move forward with sweeping insurance reform, public program expansions, subsidized purchasing pools, delivery system and payment financing mechanism changes, comprehensive prevention and wellness issues for the first time. We've thought about it. We have a pretty good understanding of what needs to be, what are the essential elements of reform, how they interact with each other. So we've invested quite a bit of policy thought and a fair amount of political energy in working through those issues. So I think that establishes an important policy foundation upon which our implementation effort can be built. And I think the task force's recommendations, your work further informs and strengthens that policy foundation. Fourth, focus matters. There's a great deal of work to be done. You talk to state health policy leaders, program administrators. You sometimes feel like their hair rhetorically is on fire in terms of the myriad responsibilities, the varied chores, etc. I think it's very important that states be clear and strategic about what is most important to do. I really believe that we have a responsibility as state leaders to identify the 5 or 10 essential implementation tasks that states need to be moving forward with now, understand timelines, resource requirements, decisions that need to be made, and to execute on those priorities as effectively and successfully as possible. Because again, implementation matters, and the decisions we make out of the blocks will have an impact, consequential impact on the foundation that's laid for the reforms to be implemented going forward. Now, Governor Schwarzenegger last week, when he stepped up and spoke last Thursday afternoon, that was his effort to try to identify or to share what the administration viewed as the essential areas that the state really has a responsibility to move forward thoughtfully, but with some speed. First and foremost, he thinks the state should contract with the federal government to move forward with creating a high-risk pool for those Californians who have pre-existing medical conditions, who are medically uninsurable. He talked about the importance of the state conforming state and federal insurance laws, the importance of developing the structure for the health insurance exchange in a way to foster competition, choice, and affordability. He talked about the importance of identifying now, where possible, prevention and wellness opportunities to begin to move forward with many of the population-based changes that we know are so essential in terms of improving individual as well as community wellness. And to leverage opportunities associated with these near-term tasks around the high-risk pool and the health insurance exchange and prevention and wellness to see how we advance our collective interests around cost containment. We know that there'll be an opportunity or an interest by some to go beyond these quote-unquote minimums in terms of things the state has to do now and perhaps accelerate reforms that are slated to be implemented in future years. I think that's a reasonable policy conversation to have, but I think it's one that we need to be considering in the context of what absolutely needs to be put in place in 2010 and what resource and capacity challenges are associated with going beyond this. But again, I encourage, when we think about focus and priorities and the task force recommendations, to look for entry points in those must-dos for 2010 for opportunities to advance the value agenda. The fifth point I'd make regards the reform opportunities beyond coverage. And absolutely, coverage matters mightily. That is where so much of the political and policy focus has been. But I think we all recognize that as important as coverage expansion is, it is insufficient in terms of driving the kind of health system reform that is so critical that the task force spent quite a bit of time focusing on. The administration absolutely sees reform as a really important opportunity to move our state's healthcare system in a direction of not only coverage expansion, but in terms of efficiency and quality improvement. And so in that respect, I think the task force recommendations are absolutely timely and helpful, and I think can really help to focus and inform elected officials and program administrators about some of the big policy questions we as a state are going to need to grapple with. Well, what are some of those questions? Probably the area of activity that I view as most important and consequential from a long-term reform perspective relates to the health insurance exchange. And the state has a very important policy question before it in terms of reaching agreement on what is the purpose, the governance, the function of a health insurance exchange. Now, some view the health insurance exchange really as a clearinghouse to improve access to and information about a wide array of coverage options. Others, including the administration, view it a little bit differently, view it more as a mechanism to promote value-based competition by expanding choice, by providing greater transparency about coverage options, and by organizing or structuring payment systems to reward plans and providers on the basis of cost and quality. I think it's really important that our policymakers think very carefully and clearly about the function and purpose of the exchange and be very clear about the alignment between purpose and function and issues of governance, issues of design, and other structural features. I think it's also important that as we move forward with establishing a framework for the exchange, we need to think very carefully about the relationship between the exchange and our existing public programs, particularly the Medi-Cal program, and seeing where there are opportunities to align incentives in our work with Medi-Cal, with healthy families, with the exchange, that promote more effective and value-based patient care. And I think the task force recommendations here potentially are really quite important and useful. Payment reforms represents another opportunity. The governor, the administration, we absolutely recognize that there are opportunities to do a lot more in terms of how we structure provider reimbursement to be much more focused on promoting higher quality, more cost-effective care. And here again, the Medi-Cal program provides a very important leverage point, if you will, in terms of advancing change. The governor last week spoke to his interests again in supporting a change in how we reimburse providers for what we refer to as never events, consistent with Medicare policy, consistent with federal reform. The governor feels we need to align California's Medi-Cal reimbursement policy accordingly. This is something the task force spoke to as well. Another example of the administration's interests around payment system change is in the context of our state's Medicaid financing waiver, which is in the process of considerable discussion and dialogue, is slated for renewal towards the end of this year or this summer. But it's a component of that renewal effort, as you know, is to institute more value-based approaches to purchasing within Medi-Cal, with a particular emphasis on both purchasing and delivery system redesign for our highest cost, most high-need populations, principally seniors and people with disabilities. So payment system redesign is an area that the task force spent quite a bit of time focusing on, and would really look to the task force recommendations to see where they're the critical entry points between work underway, such as with the waiver, or work that's required associated with the new federal reforms. A third area that I'd call out relates to the task force recommendations around population-based prevention and wellness strategies. And I really want to commend the task force for taking a broad perspective to wellness. Clearly, coverage and delivery system reform is critical. We recognize the importance of coverage and the delivery system in terms of improving access to prevention and early intervention services, improving the health and well-being of our low-income populations in particular. But we all know that it's not just about the insurance card and the delivery system in terms of improving population-based health. And so I was really excited, and the governor's very excited, to see the task force step up and recommend a number of strategies that emphasize the importance of the environment and steps to take to promote environments that really encourage people to make healthy decisions in terms of their nutrition, in terms of their physical activity, in the context of where they live, where they work, where they play, where they go to school. And here the health reform and what California has tried to do and the task force recommendations, I think, align very nicely. The task force is bringing a important and broader voice, if you will, to population-based prevention. And I think that voice will be an important one to join with more traditional public health interests in terms of advocating for federal funding, which we hope there may be an opportunity this year to accelerate to support some of the community-based prevention efforts. I would close with a word about capacity, because capacity does matter. And I'm a big believer in calling out, the elephant in the living room. And it's no secret to anyone in this room that California is faced with a few challenges. And it's a fair question to say, does the state have the technical and administrative and fiscal capacity to meet the new responsibilities invested in states in terms of reforming the state's healthcare system and moving forward with the new requirements? Governor Schwarzenegger is absolutely committed to working as collaboratively as possible within state government in terms of the executive and the legislative branches, as well as with the federal government. Federal support in particular is absolutely essential to help California make a responsible transition to the comprehensive reforms contemplated for required for 2014. Our Medi-Cal waiver is a really good example of an effort that the governor and the legislative leadership are focusing on is absolutely critical to investing in our safety net system to help move forward with coverage expansions and service and delivery system redesign and payment reform to help bridge to the far more significant changes come 2014. We are also working very collaboratively with our foundation partners. California is very blessed to have some fabulously excellent foundations, both in terms of their financial resources and, frankly, in some respects, even more importantly, their intellectual resources, that they have been very generous in investing in so many ways in our state. And we certainly look to I know we have foundation colleagues here, so to be very clear, we're not looking to the foundations to backfill deep Medicaid program reductions in recent years, which clearly are a challenge to us, but rather to invest in really our intellectual capacity in research and analysis and the kind of technical assistance and staff support that really is going to be so critical, both within the executive branch as well as within the legislative branch, to ensure that California has a good shot at responsibly planning, designing, and implementing reform as possible. And finally, partnerships with groups like the New America Foundation, with the folks who are represented on the task force in terms of business, labor, consumers, healthcare providers, health plans, and others. Absolutely indispensable in terms of informing and supporting California's responsible implementation. As Leif noted a moment ago, this report represents a beginning, not an end. The good news is the beginning is at a very interesting and important time relative to the state's effort to move forward with the essential must-dos for 2010. I really am very eager to hear the conversation we're about to have and to dig more deeply into the task force recommendations and to see where there are those entry points, where there are opportunities given the 2010 policy and legislative agenda around implementation to bring some of these concrete recommendations to bear in a really fruitful and effective way. Timing is everything. And we have some very big issues we need to be dealing with before the legislature adjourns in 2010. And if David Panish were here, he would be able to give us precisely the number of days and hours and minutes that remain. I will soon be absorbing this myself as well. But the point here is that time is limited before our legislature adjourns. And so I really want to encourage the task force, New America, and others to really focus on the essential work that has to be done in 2010 with an eye towards using those to-dos as the opportunity to really leverage reforms that offer the most potential in bending that cost curve and bringing greater value to our state residents. As the governor said last week at his press event about reform, he said, with the right partnerships in place, we can ensure all Californians have quality health care. And I know working together we have a good shot of actually taking the ideas and the concepts and the policies that every single person in this room has worked on for many, many years and beginning to make them a reality for the people of our state. It is much needed. It is long overdue. We have a great opportunity, and working together, we're going to make it happen. So thank you very much.
Hi, I'm Michael Weinberg. I'm Senior Research Fellow at the New America Foundation, and I was the Staff Director for the Task Force. I'd like to thank Secretary Belcher for such an extraordinary speech that really helped sum up all these issues. So thank you very much for that. I like that she focused on the importance of implementation. Now, about 2 years ago, my wife and I had a baby. And all the focus was on the delivery. And then they give you this baby, and you have to take it home, and you have to raise it. But we didn't really focus on that part of the, task at hand. And in some ways, I feel like the same thing is true of healthcare reform. We're also focused on, is it going to pass? Is it not going to pass? Do we oppose it? Do we support it? And not so tremendously focused on, well, how do we actually implement this if it in fact gets born as it did? And so this task force was one of the groups that was really looking at how we can get better value for medical spending, both through federal health care reform and outside of it. I want to thank the folks here on the panel and the other representatives of the task force. It's been a real honor to work with you and to learn from you about these issues. We're going to go through the members of the task force, and then we're going to have a Q&A session. I've asked them to keep their opening remarks somewhat brief, and I will keep my introductions of them somewhat brief, but I want to give you a sense of just exactly who we're going to be talking today. First, we're going to have Steve McDermott. Steve is the CEO of Hill Physicians Medical Group. He's been Chief Executive Officer at Hill Physicians since he helped organize it in 1984. Hill is the largest independent practice association in the country and one of the largest medical groups in California. They have 3,000 participating physicians, over 25 affiliated hospitals, and 300,000 enrollees. With Steve today is Alvin Sokoloff. He is a doctor. He is board certified in family practice and practices in a 4-person group right here in Sacramento that includes his brother Ron. Alvin has been a member of Hill Physicians since 1996, currently serves on its board of directors, and is their primary care medical director for Sacramento. David Lansky is president and CEO of Pacific Business Group on Health. He's a nationally prominent expert on health information technology and promoting value in medical purchasing. The Pacific Business Group on Health is a coalition of 50 large organizations that purchase healthcare on behalf of 3 million people. He's also co-chair of Cal eConnect, the nonprofit organization that will oversee the creation of a health information exchange for California. John Ahrensmeyer, to David's right, is founder and CEO of Small Business Majority, a California-based national nonpartisan organization founded and run by small business owners that brings the voice of America's 28 million small businesses to the public policy table. Prior to starting Small Business Majority, John was the founder and CEO of ACI Interactive, an award-winning international e-commerce company. And finally, we're honored to have Jean Fraser here. She is the chief of the San Mateo County Health System. This system includes the county hospital, 11 clinics, and the behavioral health, public health, and aging services for the county. Prior to joining San Mateo, she was the chief executive officer of the San Francisco Health Plan that provides affordable health coverage to 53,000 moderate and low-income San Franciscans. So please join me in welcoming the panel. And Steve, if you would like to start us off.
Thank you. First, these guys did a fabulous job. I mean, there's an impressive group of people, and just a smattering of us are here today. But taking all of these different folks that have represented on the task force for the past year and taking our input and trying to make sense of it all and bring it together, the New America Foundation and Michael and Leif really deserve an awful lot of credit. When I saw the report, it was like, oh my God, this actually makes sense, because if you were to sit in this room and listen to us, I didn't know how they were going to make sense out of it, and they did a great job. I know you're all going to read it carefully, but at least read the executive section of it. It's very good. What we're going to talk about, and Alvin and I are going to just chat a little bit about, is how this translates into some areas that we're working on today. We all breathed a sigh of relief when healthcare reform did pass, for all its goods and bads, but this actually provides us an opportunity to get up and bat and start swinging away at a problem. Pop quiz. We were doing pretty well in the 90s on bending the healthcare trend, and there was actually a year in the middle of the 90s where we actually had price of medical care and premium. The premium price of medical care was actually below 0%. I think it was 95, 96. Okay? And I was part of that and very, very proud of that. I spent most of my life uninsured. I know what it is like to be uninsured, to be on welfare. And I would have to say that starting in 2000, it started heading the other way. So pop quiz, in the past 10 years, what's the premium price increase been? What percentage over the total?
Over 100.
5 times CPI. Okay, it's about 145% in the past 10 years. And so we have a monumental task in front of us, and everyone in this room knows about and is affected by the affordability of healthcare. If you're not personally, you know people are, your family, and so forth. There's an initiative that we started when we started Pay for Performance with the Integrated Healthcare Association about 10 years ago, it was in the middle of this period where the price was coming down, and I thought we had our arms around it. And it was very much like Kim said. We actually had a model under managed care where we had competition driving price down, and I thought what we really need to do is improve service and quality. And Pay for Performance was initiated on the basis of transparency, report cards, and paying for service and quality, something that isn't paid for generally in medical care. The good news is that was actually a fairly successful launch. The bad news is when we sort of looked up and looked around at the landscape and seen, while we were doing well on Pay for Performance in terms of the report cards and the metrics, we suddenly found ourselves swamped by the affordability question. And so the IHA and the steering committee of Pay for Performance has adopted what we now call value-based contracting, and we're switching, and we're not switching away from quality, but we're saying you have to match up quality with affordability, and it really means value, and that's a big turn. My long-term dream that I know, because I know many of you in the room, my long-term dream on Pay for Performance is that in 10, 20, 30 years from now, that the state of California can look at the total amount of money that the medical care delivery system is spending in California and figure out what is the return on investment we're getting in terms of improving the health of the population of California. And I would say right now, we're not getting what we should be getting. And if I had to say, and I said to Michael, the most important recommendation long-term in this thing is the one on the public health and really getting at the underlying. So I find myself day in, day out, and Alvin knows this too well, what we're working on is taking care of the train wrecks, right? And trying to minimize the pain and suffering as the consequences of our culture and overweight and disease and chronic care and so forth. And we need to get ahead of the train wrecks. And that's where, as Kim mentioned, we build delivery systems and get into prevention and public health. I'm going to ask Alvin to make some comments about our CalPERS initiative, but it basically goes back to a year and a half ago. And we had this unique situation where in Sacramento, Bill Physician cares for about 40,000 CalPERS members. And we have this three-legged stool where the hospital, Mercy Hospitals, Bill Physicians, and Blue Shield collectively responsible for these 40,000 people, but we were not working together. And I thought we had a wonderful opportunity to be accountable for the care of these people and accountable for the cost and quality. And in a nutshell, that's the concept. It's we launched it January 1st. We're 4 or 5 months into it. We were probably a little overambitious, but that's my style, and we committed to a 0 premium increase where CalPERS probably would have expected a 7, 8, 9% increase. And we said we're going to take responsibility for and be committed to doing that. So that meant finding about $15 million in savings somewhere along the line. We're about 17 initiatives along. We're halfway there, which I think is a great success. It's probably a multi-year effort, it's great to be able to show how a health plan, a hospital system, and a physicians group can work together to try and reduce inappropriate, inefficient care, improve the quality, and lower the cost. Alvin? By the way, Alvin's not only born and raised here, but he's actually a graduate of Davis. So local boy makes good.
Yeah, thanks, Everett. Thanks for having me here. Fish out of water, I think. When they were talking about capacity earlier, I thought someone was going to say I had to get back to my office and start working. And we know that primary care capacity is going to be an issue down the road. In fact, some of the reality of what I do is, a couple years ago I wouldn't be here. A couple hours ago I saw a patient, needed a CT scan, turned out had a pulmonary embolism, get on the phone, call the hospitalist, all the information transmitted electronically, patient admitted to the hospital within about 45 minutes. past, I would be in the hospital right now taking care of the patient, trying to make arrangements, communicating, sending information. And some of the things we're doing now with Hill physicians and all the large medical groups are really trying to alleviate that, make this a more seamless process of care. And when I look at my role is as a family practitioner. That's what I do, but I also wear the hat of primary care medical director at Hill Physicians. Being part of a large group helps me do my job better. It allows me to provide a higher level of quality. Utilization is always an issue, but I think with the vision of higher quality. When we started the CalPERS program, one of my jobs was to roll this out to all the primary care doctors and now specialists in our organization in Sacramento. A lot of discussion, a lot of talk, and when we had these discussions, the one thing is I'm sitting here now reflecting on it. The term quality is used a lot. The term cost never came up. It was all about quality. It was all about how we could do a better job at what we have been trying to do. And in fact, so now what we're doing with CalPERS, we're partnering with CHW, we're partnering with Blue Shield, and we have a better relationship where our resources are more aligned. We have electronic capability that we did not have before. Hill supports a lot of that, taking our office and our other primary care doctors' offices, soon specialty offices, into an area we've never been before. We can do a better job. And so some of the nuts and bolts, and again, I'll only take a few seconds of your time, with the CalPERS initiative, we have better case management. So our patients who are ill, our heart failure patients, our cancer patients, they have more oversight. There's more opportunities for care. And this comes from not only the Hill physicians, but also from Blue Shield. Pain management. We have pain management programs. We're actually getting our physicians trained. We're looking at different modalities of pain, not just interventional modalities, behavioral modalities that are made available to us that never were here before. Pharmacy management. Patients now get a pharmacist reviews their prescriptions, our opportunity to look at adverse events and to improve our generic prescribing. It's a huge cost opportunity to use generic prescribing in a similar like situation in class. Disease management. We've never had opportunities to partner with the health plans, and now we do. In the past, there's a lot of parallel services regarding all kinds of disease management for diabetics and patients with hypertension and renal failure and heart disease and cancer patients. And now we're partnering with the health plans to provide really more robust disease management, more education. We're discharge planning from the hospital. Patients are getting into our offices in a more timely fashion. We get to communicate with the hospital, two-way communication, so they are getting the information we have. In the past, the patient would go to the hospital. They didn't know what we were doing. Now they do. They know what medications the patients are on, what problems they've had in the past. And also a real touchy area that we focused a lot on. As a result of this initiative, uncomfortable areas, end-of-life care. We haven't been trained in end-of-life care. Have those tough conversations. Trained on having difficult conversations. These are all areas in the last year we've focused on at Hill in partnership with CHW and Blue Shield to bring to our physician offices. And as a result, I think have improved the quality of our care. I think we do a better job. I know we can do our job better. We have more resources. And so, it started off to get the attention of our docs because we understand we need to do a better job. We understand that we need to improve quality, and we understand that we have to do it at a, I think the term was value, more efficient way. And I think if we improve quality, which this initiative is all about, we're seeing that can happen. And so primary care docs in Hill are happy with the initiative. It's more work, but we have more resources. So I think I'll leave it there. And thanks for giving me a few minutes of your time, and hopefully we'll answer some questions later about the initiative.
Great. Yeah, thank you so much. I was so excited to have you as a part of this because at these health policy conferences, a lot of times we talk about policy and not so much about how this actually works on the ground. So to have somebody who was just, ordering a CAT scan, a couple of hours ago involved in this.
The truth is he didn't believe anything I said.
So it's good to get verification, trust but verify. All right, David.
Thank you. Nice job.
Good afternoon. Let me add my compliments to New America Foundation and Leif and Micah and the committee members I was fortunate enough to work with on this project. It's a real pleasure to have a collaborative outcome and there's often issues that we all are contentious about. But here was a case where I think a very wide array of people found some common ground of how we need to move forward to achieve some of the goals that Kim described earlier. So it was a pleasure to be part of it. I was asked to talk a little bit about health IT, information technology, which you won't find a chapter in the report on health IT. And I think as you read through almost any page, though, you'll find, as Dr. Sokoloff just suggested, that having better information, sharing, communication, taking advantage of having clinical information at the right place at the right time is a prerequisite of almost everything else we're talking about in the report. So I wanted to do a little detour around where we are with health IT and hopefully suggest to you how we need to move forward in that area as in support of the recommendations in the report. For a while, it was seen as a panacea. A lot of people, including the president, talked about health IT and electronic health record adoption as the magic that would make all kinds of improvements in cost and quality happen. And now, as we've all said today, the reality of implementation is upon us. And for the last year or so, since the stimulus bill was passed, there has been a massive national effort to help doctors and hospitals in particular adopt health information technology. And I've been part of that both nationally and in California, and there are some lessons from it. The hope clearly is that we now have an enormously complex science base, tremendously powerful technologies that can be deployed for great good and can be overused if they're not deployed appropriately. They can also cause harm and if they're not used well. So we have to have some intellectual tools into infrastructure to support the correct use of all the capabilities we now have. And unfortunately, in many circumstances, we don't have that. And from my constituency's point of view, the other missing dimension is accountability, as Steve alluded to. We don't have information as those who pay for health care for 160 million people. We don't have information to tell us if we're buying the right services, getting good value, delivering benefits to the people we are helping to pay for their care. So, and the lack of accountability also means we don't have a competitive environment. Again, as Steve described the 90s, there was an opportunity at one point to see organized delivery systems competing with each other on a transparent basis of cost and quality. We don't seem to be at that point right now. So the purchasing community is really desperate for information to explain these enormous increases in cost. I talked to one small business, John will probably talk about this, that has a 58% rate increase for next year. And many of our members have 18, 20% rate increases for next year. And the consequence of that, of course, is loss of coverage, and perhaps Gene will talk about that. So down the row here, we're all victims of this inefficient and non-competitive healthcare system. So the point of the health IT intervention, if you like, in this difficulty we all have, is it provides a platform for doing many of the reforms that are described in the report you have in front of you today. So, for example, we talk about paying for risk-adjusted outcomes. Well, how do we know what the outcomes are for patients, and how do we risk adjust them so we can make appropriate payments? We don't have any information infrastructure to execute that objective yet across the board. So we need the IT to do that. We talk about measures of value so that all of us can make better decisions of where to seek care and which care to seek. We have no information to do that today. We talk about preventing readmissions. That requires care coordination, which we're woefully inadequate at doing, absent the kinds of projects that Dr. Sokoloff just described. We talked about liability protection if physicians follow the evidence. How do we know if physicians are following the evidence? What tools do they have at their bedside to guide them in that decision? So all of these things, patient decision aids, administrative simplification, all depend upon improving the information availability and flow in our system. So there's a federal program that started a year ago to distribute about $4 billion to California providers to take advantage of electronic health information technology and hopefully solve some of the problems I just summarized. And this program has been organized under a concept that's very important, I think, called meaningful use. And the notion is not that doctors and hospitals will get a check from the federal government to buy great computer systems, but that they will get a check from the government if they use the computer systems to meaningfully improve the care, quality, and efficiency of what they do. So the question is, how do we know if people who take advantage of this money and buy IT systems are actually improving cost and quality? So we need some criteria to do that, and the government and various committees have been trying to develop those criteria, and they've organized it into 5 areas, and I think it's instructive for where we go with the task force. The 5 areas, the first is one big bucket called quality, safety, and efficiency, and there are measures of whether doctors and hospitals are improving quality, safety, and efficiency when they use technology. The second big bucket is patient engagement, and this is really the disruptive element of this strategy. The expectation is that increasingly doctors and hospitals will fully engage their patients in their own care, in understanding their care, in knowing about their own conditions, and in self-managing to a larger degree. So that will become a measured criterion of getting money to buy IT, is whether you are working more closely with your patient at self-management, communication, and knowledge about one's own situation. The third big bucket of getting this federal money is care coordination. So you're no longer allowed to live in a silo and do a wonderful job within your silo. You have to demonstrate you are using information to coordinate care across the continuum, much as the Hill CHW project we just talked about. The fourth category is population health. You have to, as an individual provider, an individual hospital, demonstrate you are serving your community and managing information and addressing the health of the population, as our report also advocates. And the final category is privacy and security. As information proliferates on the internet, how do we know that we are all protected in the way that will be used and shared around the network? So there are 9 criteria out of this whole bucket which require information to be shared, to be exchanged with other people, with patients, with families, with doctors, with caregivers. And that means, in turn, we need to connect everybody to each other across an internet-based network. And that's what health information exchange is all about. Now, these are really radically new paradigms in how we organize healthcare. To the extent that doctors and hospitals in California do these things, buy the electronic technology, connect to each other, share information, satisfy these federal criteria, and get the money, we will have a really different healthcare system 5 or 10 years from now than we do today. And we will have the information products, if you like, to do the things that are in the New America report. And if we don't get this done, the IT adoption, it'll be very hard to succeed with a lot of these components. So the last thing I just want to mention is, why do employers like my members care about this area at all? Why am I spending my time on health IT? And I think it's because they see this as the platform to transform healthcare. We had a hearing in Washington last week on the patient engagement goal, and one of the witnesses challenged us to say the federal government should say half of all healthcare will be delivered in the home by 2020. And the whole committee just gasped and said, well, that's a different way to think about healthcare. It's a different way to think about who we pay, what's a fee-for-service unit that we pay for, how do we evaluate whether we're getting good value for our money. So there are beginning to be discussions, even in the federal policy level, of just transforming the paradigm. If we do have a rich information environment, we can think differently about who's getting the benefit of population health services, public health services, medical services, and so on. So our employers are looking forward to a transformation in what information is available at the bedside, who's accountable for clinical decisions and how we evaluate that accountability, how we can be smarter purchasers and drive competition in the system, how our employees and their families can be engaged in their own health care, and ultimately that there are really innovative new delivery models like we're hearing a little bit about today. What we need to see is a disruption in the status quo of healthcare and the opportunity for new entrants to come in and think differently about how to improve health. Not how to improve the healthcare system, but how to improve health, which will in turn drive improvements in our system. So again, I want to compliment the foundation and the supporters of this project for getting it to this point, and encourage all of you to choose doctors who are making meaningful use of technology, get engaged yourself, get your own information, and be part of the transformation. Thanks.
Great. Thanks, David. John?
I also want to thank Leif and Micah and New America Foundation. It was very interesting being on the panel. I'm sort of a newbie to the healthcare world compared to some of the folks who've been sort of chomping on these issues for a long time. And I was really struck with a lot of different stakeholders and different perspectives in all of our meetings. There was really a tremendous desire on everyone's part to try to come together and really figure out how we could really forge some solutions that are going to benefit everyone in the system. I'm going to talk about the exchange, and as Kim and others have already indicated, setting up the exchange is absolutely critical to making healthcare work. Just really quickly, what does the national bill provide? There has to be an exchange set up for folks in every state by 2014, essentially a marketplace where businesses and individuals can purchase insurance. And the law does allow for separate exchanges between businesses and individuals. We're going to talk about a little more about that later. The states can actually opt to not set up an exchange, but thank you, Kim and Governor Schwarzenegger and everyone for stepping up and saying, no, we're going to really try to make this work. The legislature's already taken action with some bills to start putting the contours around an exchange. So clearly California is not going to be one of the states that opts not to have an exchange. So I want to step back for a second and look at the current healthcare environment, particularly as it relates to small business and the exchange. Over 60% of the uninsured in California are employed. Of the uninsured are unemployed. 4 million employees don't have health insurance, and half work for employees of less than 20. Half work for employees of less than 20 employees. Businesses with fewer than 10 workers employ just 11% of the workforce, but 35% of the working uninsured. And finally, California has 2.8 million self-employed entrepreneurs, 30% of whom do not have insurance, which is almost double the rate for the population as a whole. So, and as David indicated, I mean, this trend is only getting worse. We're seeing double and in some cases triple-digit premium increases. So, suffice it to say, addressing the needs of small businesses and the self-employed is critical to the success of the implementation of healthcare reform. And indeed, the exchange is critical to that success. 8.4 million Californians are going to be eligible for individual or small group coverage in the exchange. Almost 4 million of those will be small business employees and their dependents, and another almost 1 million will be self-employed. Almost 3 million Californians, many of whom are small business employees, will be eligible for subsidized coverage due to income level or through employers who will benefit from the small business tax credit. And those subsidies are only going to be available in the exchange starting in 2014. So I'm going to talk a little bit about what is the value of the exchange in health reform. First, it's probably first and foremost is controlling costs, cost containment, cost stability through true competition and other mechanisms. Choice, providing an array of choices for businesses and individuals to find that they don't have right now. Convenience, one-stop shopping for enrollment, eligibility, premium collection. Transparency, a clear explanation of costs, benefits, performance, satisfaction that's available to everybody. And finally, an opportunity to drive some of the innovation that Steve and David have already talked about in the healthcare system as a whole. The exchange maximizes purchasing power, creates managed competition, pools employees to spread risk, simplifies comparison and decision-making, handles all program administration, eliminates job lock and enhances portability, and assures participants meet common standards for all. Really, at the end of the day, the top priority for the exchange is financial sustainability and long-term success. And for this, the exchange structure is absolutely critical because the exchange has got to be robust over the long haul. Now, obviously, we've had issues with exchanges in the past. PAC Advantage, obviously, is an example of that, where you end up with adverse selection, death spirals, and we need to learn from those experiences. But I should point out we have a huge game changer now that we didn't have before, and that is the individual mandate, the fact that everyone has to be in the system. This is not going to solve all of the problems that the exchanges have experienced in the past, but it's a huge step in the right direction that we didn't have before in the system. Some of the goals of a well-designed exchange are to reduce extra premiums and avoid price volatility, offer a choice of multiple insurers, providers, and delivery systems, to drive innovation, as we've said, and to encourage wellness prevention and chronic disease management through incentives. We have to remember the exchange is going to be most effective coupled with many of the other reforms that are in the system, particularly insurance reforms such as guaranteed availability, no medical screening, and no exclusion based on pre-existing conditions, and a whole host of the other reforms that are in there as well are going to help. The exchange is going to be a critical part of that, but it's also going to help make the exchange successful. So, as Kim indicated, how should the exchange be set up? We really do need to align purpose and function. I'm going to touch on some, but not all, of the key issues that really need to be decided, some of which are already being debated in the various pieces of legislation in both the Senate and the Assembly right now. First, probably the biggest issue is size. Size does matter, and it's pretty clear from talking to most people about this that the bigger is better. So what does that mean? It means you're going to have a better likelihood of success if we combine the business and the individual exchanges. The law allows, it requires the businesses up to 50 employees be part of the exchange initially, but it allows for businesses up to 100 employees to be involved. Clearly, If you allow that to expand to businesses with 100 employees, you're going to have a bigger, more robust exchange. Along those lines, businesses of over 100 employees are going to be eligible to join starting in 2017. Again, trying to make this as robust as possible, we think that we should look seriously at allowing that to happen when the law does allow for it. And the policy experts will tell you that really the best way to ensure a robust exchange is to have it be the sole source of our insurance. We had many conversations with many policy experts during the healthcare debate. The reality was, during the healthcare debate, this was not politically feasible, and we certainly think it's probably not, although policy-wise perhaps the best way to go, it's probably not politically feasible. So we're likely to have an exchange, insurance sold within an exchange and sold outside the exchange. However, it's going to be that much more critical to assure that the exchange isn't disadvantaged by that. And to start off, we have to have the same rules apply inside and outside the exchange, and that has to be really monitored and regulated closely. The next big issue with an exchange is it active or passive? Kim used the term clearinghouse for a passive exchange. We definitely feel, and most of the other stakeholders we've talked to, including other business organizations, feel that the exchange really does need to be active. It needs to negotiate based on price and quality, much the way CalPERS does. A big issue that's going to be debated is the issue of benefits. The federal law sets minimum thresholds of 5 different benefit levels. The states have the option to add to that. There's going to be a debate. Do we add to that? Do we not add to that? It's fairly complicated. I'm not going to get into all of the details here. But needless to say, we think there needs to be, the exchange needs to be integrating what's comprehensive with what's affordable, and again, making sure the standardized benefits packages are offered both inside and outside of the exchange. Finally, governance is going to be critical to the way the exchange operates. And again, from where we sit now, it feels as if an independent nonprofit entity that is somewhat separate, although connected to government, is the best way to go. And we do feel strongly that the board composition of that entity must reflect all of the stakeholders in the debate. So what are the next steps? There are already bills, as I said, in the legislature regarding the establishment of the exchange. We really appreciate the fact that Governor Schwarzenegger and his team are working hard on this issue already. It's clearly not too early to weigh in on these issues. We're telling all of the small businesses we talk to out there that you need to understand what's in the exchange. We want to hear from you. It's not too early to weigh in. We're going to be conducting a listening tour around the state of small businesses. We're actually going to be collaborating with New America Foundation on that. And we want to hear from businesses. It's really not too early to be engaged on this. There are some resources out there that are going to be important for folks to know about. The HHS is going to have their website up by July 1st of this year to get information about it. It's going to include eligibility, availability, premium rates, cost sharing, and how much is spent by each plan on medical care versus administrative costs. And the states will receive funding this year to establish a health insurance consumer assistance offices and ombudsman program, including a call center. So this resource is going to be available. We have resources on our website, including an interactive calculator about the small business tax credits, FAQs about the reform legislation. So again, it's critical that everyone weigh in on this issue because the exchange has to be done right. Thank you very much.
I believe pictures really are worth thousands of words, so we're going to have some pictures here. My name is Jean Fraser, and I am the health director for San Mateo County. It's San Mateo County, and I think every public health system, we are really on the front lines of watching the cost of care go up. And that puts us in a double whammy situation, because not only is the cost of care going up, but actually the number of people we have to care for is going up. As a result of the recession and people losing job-based employment job-based coverage, we in San Mateo County, which is one of the wealthiest counties not only in California but actually in the United States, are literally facing thousands and thousands of people coming to our healthcare system needing care. And what is it they need care for? It's for chronic diseases that are utterly preventable. Let me say that again. 75% of the spending in America in healthcare are for chronic diseases which are absolutely preventable. But they're not preventable by going to a doctor's office. They are preventable if we change the communities in which we live, the food systems that develop and market to us the food, and the transportation systems that move us around in our daily lives. So let me just give you a couple of statistics that I think will show you what we're really facing. In 1960, 13% of American adults were obese, and 4% of the children were. In 2008, 34% of American adults were obese, 68% were overweight, and sadly enough, 1/3 of our children were overweight and 1/5 obese before the age of 18. The truth is that a child who is overweight between the ages of 10 to 15 has an 80% chance, put it another way, is going to become obese by the age of 25. So in 2001, the Surgeon General said we were facing an epidemic just in diabetes, right? What are we trying to do about this? Obviously, we've got to focus on our healthcare system, and I strongly support every single one of the recommendations of the task force. They're really critically important for our healthcare system. But we've also got to look at our communities. We've got to look at the factors that have produced this really extraordinary change in the health of Americans. All right, so the last two recommendations, and I'm very proud that this is actually in these recommendations because honestly, task force like this rarely think about what are the primary causes of the incredible disease burden that is driving the increase in cost. We have two recommendations. The first one is to change our food environment. And what do I mean by that? I mean the idea that, in fact, corn and soybeans, what are called commodity crops, are subsidized by the federal government. But fruits and vegetables, oranges, apricots, in fact, a lot of what we grow in California is not. And so while the price of those cheap foods, the Cheetos, I call them the O's, the Cheetos, the Doritos, the O foods have gone down, the price of oranges and bananas and other foods have gone up. In addition, we have a food system that's really focused on marketing poor foods, high-calorie, low-nutrition foods to children, because we know that preferences that children develop will last their lifetime. So some of the things that need to be done are we need to subsidize fruits and vegetables in the same way that we subsidize commodity crops. We need to change the marketing rules. This is very radical, but we really need to think about the fact that children don't make these choices, right? They are made for them. So we've got to really look at advertising and marketing food, particularly for children. We need to increase the price of sugar-sweetened foods. Straight up. We have to start to change the price differential. So whether it's a tax, or I would make the argument you could even do a mitigation fee. For those of you who don't want to do a tax, we need to start increasing the price of those foods, particularly sodas. And finally, on a local level, we need to rethink about where we put fast food outlets and where we allow groceries, so that those food deserts that we see, where you pass literally 5 to 10 Arby's and McDonald's, et cetera, before you get to a grocery store, we turn that around. So that's our food environment. But pictures really matter when we talk about our physical environment in terms of our transportation system. If there was one and only one thing that I could write a prescription for, and I'm not a doctor, so I can't write a single one, but if I could write a prescription, it would be that we would get more physical activity. But it is not possible for people to add that to already very time-stressed days. I have 2 kids, 2 working parent family. There is no way we can exercise in addition to everything we have to do. Right? But if we start to make the way we move around during our days, the way we get our activity, we can really make a difference. So this is a quick picture that I'm going to go through quickly but it's actually from San Mateo County, again, one of the highest ranked communities in California for health. And these are just some examples of how we collectively make it very hard for people to walk or bike or take public transportation. So this is what I really want you to focus on. The red line is obesity prevalence among adults. Okay? And we're going at the bottom, you'll see a number of different countries. The green line is the percentage of trips done over a day that are done using walking, biking, or transit. And why do we include transit? Because almost every trip starts and ends with a walk or a bike, right? So you can see it's a perfect X. As the percentage of trips taken, essentially non-automobile trips, increases, the obesity prevalence decreases. And I'm going to pause for 1 second and tell you this great story, because I was showing this slide to a group like this, and some guy raised his hand. And he said, I run a business in San Mateo County, and I recruited someone from Switzerland. That's the country over there at the end. And she came to live here. And after 1 year, she had gained 25 pounds. Oh, my God. And he said, we started talking about it. I did not ask how they got onto that topic, but he said, we started talking about what had happened. And everyone in the office said, oh, it must be the American food. We have such a terrible diet. And she said, no, actually, I go to the grocery store and I make the same food that I used to eat in Switzerland. She said, the difference is, in Switzerland, I lived on the 5th floor with no elevator. I would walk up and down, obviously, to get to my apartment. I would walk down in the morning. I would walk about 5 blocks to take the tram. I would take the tram to work. It was about 3 blocks to my office. At night, I would return on that trip. And my grocery stores and my services were all pretty close by. So on Saturdays and Sundays, I would walk to these places and I would get my food. She said, here in San Mateo, I live in my apartment. I take the elevator down to the garage, which is right underneath. I get in my car. I drive to my office, where the garage is right underneath. I take the elevator up, et cetera, et cetera. I come back down. I get in my car. I drive to the Safeway. I walk into the Safeway. I come back out. She literally gained, and think about it, it's not that much, 2 pounds a month, merely by changing how she moved herself through the day. So let's move along. If you don't believe that it really matters in the United States, here's an example of what's happened in the United States. Our obesity rates correlated with the decrease in trips by bicycle and by foot. And where we really see a dramatic change is among children. 66% of children used to walk or bike to school. It's now 14%. So all those parents who think they're doing something good for their children by driving to school, I have a message. You're not. Okay, so here's the most frightening thing from a public health perspective, and that is that if we do nothing, not only will people continue to get sick, and many, many more people will get sick. By 2035, 44 million Americans will have diabetes. And right now, if you're a child born in 2000, you have a 38% chance of getting diabetes, right? For which we cannot cure, we can only spend money to treat. If we do nothing, our children will live shorter and sicker lives than we do. I want you to understand that. This is the first time in American history that we are dooming our children to live shorter lives. This is a picture literally of where we're already seeing life expectancies decrease. So let me tell you what we should do on these things. We need to change the funding stream so that we really prioritize walking, pedestrian, public transit over highways. It's been the reverse for many, many years. We need to implement SB 375. We need to defeat the initiative that is on the ballot to put this off, because that will really make a big difference in how our communities are structured, and at the local level, we need to be making much better decisions. I know you want me to get out of here. Let me just show you a picture of something beautiful, because you have to end on a positive, which is that this can be done. Iconic place. This is Times Square in New York City. The public health director, who has now become the head of the CDC, went and talked to the mayor, said, it's crazy what's going on here. We've got to start changing our systems. He talked to the Department of Transportation. This is Times Square. It took him a week.
I'd like to thank Jean Fraser. So in addition to talking the talk, she also walks the walk, or rather bikes the bike and transits the transit. She came up here from San Mateo today on the train, and then, I don't know, in the back somewhere is that little bike that she unfurls and biked over here. We're going to hear from the Assembly members who have joined us and then have our question and answer session. I believe that Assemblymember Nathan Fletcher is here. Assemblymember Fletcher was elected in 2008 to represent California's 75th District, which is in San Diego. He serves as Vice Chair of the Assembly Health Committee. In his first months in office, he joint-authored Assembly Bill 23 to help employees laid off from California small businesses retain their private health insurance. Prior to his election to the legislature, Assemblyman Fletcher served in the United States Marine Corps, which included spending 8 months in the Sunni Triangle region of Iraq and receiving numerous medals for his exemplary service. So he's one of the few people who has actually done something more difficult than health care reform. Assemblymember Fletcher.
Thank you for having me join you today. I think the legislature has about an 11% approval rating, so I still get a little excited every time someone asks me to join them. You mentioned my time in the military. I had a very humbling experience right out of the gate. It was the first office I'd ever run for. And the day I announced was kind of a fun day. You know, I'd never run, and so I announced, and we had a TV camera come out and do a story and a newspaper, and got endorsements and raised money. And that evening I was on the phone with my mom. I was pleading for her vote. She's a fairly passionate member of the other party. And I said, Mom, you'd vote for me, right? She said, well, not in the primary, son. But as we were talking, the phone clicked on the other line, and I clicked over, and I said, yes, hello. And the guy said, this is Robert with the Marine Corps Times. May I speak to Mr. Nathan Fletcher? I said, oh, of course. I clicked over. I said, Mom, I've got to go. I've got a reporter on the phone. I said, I'm really important now. I'm running for office. And I said, it's a reporter with the Marine Corps Times, big publication in the military. I said, everyone reads it, and this is really great. I said, I'll have to talk to you later. I'm very busy now. And she laughed, and she said, I love you, son. She said, I'm proud of you. And she said, call me back on the voting thing. But as I clicked back over to the other line, I was so far down the road with what I was going to say in the interview, and I knew I wouldn't get a picture on the cover of the Marine Corps Times, but they have these 3 little boxes across the top, and I thought, man, maybe if I do a good interview, I'll get a little picture in there. And all my buddies would see it. And I said, Robert, sorry to keep you waiting. I said, Nathan Fletcher, candidate for the California State Legislature, combat veteran, United States Marine Corps. I said, what can I do for you, sir? And he said, no, Mr. Fletcher, the question is what I can do for you if you renew your subscription today. So we started our career being humbled, and I think we always try and remember that. In that same vein, I'm not going to purport that after a year and a couple months in the legislature, I'm anywhere close to a healthcare expert to a group of people who have done it for your entire life. One of the downsides of term limits is you get elected and you get asked to be vice chair of a very complicated committee in healthcare. And so, many of you work on it for 10, 20, 30 years, and you still learn new things every day. And so we do work hard, and we do try and tackle some of these issues, and I'll share with you a couple thoughts. But prior to being elected, my healthcare experience consisted of having had 11 arthroscopic surgeries from sports. I was very popular with doctors, not so much with insurance companies, but didn't really know a lot. What I did know is came out of an experience of one of those surgeries that I think shapes kind of my approach to how we tackle it, and that was what it was like to be uninsured. Shortly after college, I grew up in a very blue-collar family. My dad was a factory worker. My mom's a social worker. I had finished college where I was covered by the school, and I started working, and the employer didn't offer it. I tried to buy a plan in the individual market. It was too expensive. I couldn't afford it, and I didn't have health insurance, but it was fine. I'm young and invincible and ate healthy and worked out, and nothing would ever happen until I very severely shattered my nose. And it was the 3rd time I'd broken it, but the previous times I'd been covered. So I called a distant relative who's an ear, nose, and throat surgeon, and I said, hey, I need you to hook me up and take care of my nose. I said, I can't breathe. It's really bad. And he said, well, I can't cover the hospital and the anesthesiologist and all these other types of things. And I said, well, what do I do? How much is it? And what if I pay cash? I can't pay cash. What do? I can't breathe. I have no health insurance. You can't help me. And he said, I don't know. And so I asked the question. I said, well, what did you do before you had anesthesiologists? If Moses broke his nose, what would have happened? And he said, well, technically I can do it under local. And so I went and sat in the office and bit the towel while he proceeded to re-break and crack and reset my nose. And so I do have some connection and sympathy to those that are uninsured, and I think it's incumbent upon all of us to try and find a system that gets as many people in the system with preventive care, with catastrophic care, with those types of things. And so I'll just touch briefly on just a couple little things, and then I think my buddy Isidore's coming, and then happy to talk. I feel like in addition to a starting point being how do you get more people in the system, a starting point has to be, and it's obvious to say, but healthcare begins with health and with healthy living. And so I'm always out there interested in creative ideas. What are innovative ideas that we can incentivize healthier living? I mean, how can we encourage people to do the right thing? There's fascinating things, I think. I think it's Sweden or Switzerland. I get them confused. One of them has a plan where you have to buy a plan for 10 years. When you buy health insurance, it has to be a 10-year plan. Because they've determined at 10 years, it fiscally makes sense for the insurance companies to provide an incentive for you to do preventive care and to work out. That's an innovative type model. Safeway's done some amazing things surrounding weight loss, surrounding different types of preventive care, working out, exercising. I think that there's a lot that a state that has over 300,000 workers can probably learn from and try and do those types of things. We had a big debate this year on discrimination in healthcare pricing based on gender. And while I don't think it makes sense to discriminate based on gender, I do think it makes sense to discriminate based on behavior. If you're going to smoke, you are going to draw more services. You should pay more for your health care. If you're going to work out every day and eat healthy and not, you should pay less. I think there has to be some creative way to try and find innovative solutions to affect people's behavior. And I think financially there's some ideas that we can do there. One area I think that relates a little bit to kind of healthy living and preventive care in particular as it relates to immunizations. We're doing a bill this year to expand kids' ability who can give immunizations at schools. If you worry about a pandemic breakout or the H1N1 thing that happened recently, if the school doesn't have a school nurse or there aren't enough people, there was no statute in law to allow a physician or a physician assistant or a nurse practitioner or someone else to come in and be able to do that. We did that. But more importantly, I worked very, very closely as a co-author the bill with Manny Perez, and he deserves a lot of credit for a bill that we're putting through relates to how reimbursements happen for immunizations. Now, I view immunizations as a little bit separate from other public policy. If you are obese, that's not a health risk to me. It is a health risk to the entire system. We have to pay for it, but not to me. If you don't immunize your kids, that is a health risk to my kids because they're going to be in public places together. And we had a real problem with the rates of unimmunized children going up. And as I talked to family physicians, as they were in the capitation negotiations, they had no leverage, and the reimbursement rates they were offered were so low that a lot of them were not offering immunizations anymore. They would tell their patients, you just need to go to the clinic and tell them you don't have health insurance. Well, that's hard because parents have a lot going on, and you saw the rates increase. And so Manny and I have been working for 2 years on a bill to basically remove immunizations from that negotiated process and say you have to reimburse at the CDC wholesale price and the Medi-Cal shot administrative cost. And to put in place a better system so hopefully we can increase the rates of immunization. So on that part, there's a lot of ideas out there. Briefly on cost and transparency, this is, we all talk about technology and medical records, and I think in some stuff that has to go a little further. I don't fully understand how a society that 40 years ago put a man on the moon with the computing power of one iPhone. I was at Apple recently. They said, you have an iPhone? And I said, yeah. And they said, do you know your iPhone has the computing power of the entire Apollo project? It's true stat. Amazing. I said, Apollo project's in my pocket? This is amazing. How a society that has that capacity doesn't seem to have the capacity or was taking a long time to get there, to apply that same type of technology as it relates to healthcare, particularly as it relates to cost, transparency. Let's open it up a little bit. There's nothing classified about healthcare pricing. There's nothing classified. I had a very classified job in the military. You don't need to know what I was doing. There's nothing classified about a lot of these types of things. Now, everybody, depending on where you sit, doesn't want to disclose your information. But I think if you do it across the board, I think you'll have some better outcomes and you'll be able to affect it a little bit. And then finally, get my little note here. The third area is access. We talk a lot about coverage and getting more people in the system, but if they don't have anywhere to go, it makes it a problem. These are tricky issues. These are really difficult. You get into scope of practice issues, and everyone has some turf that they have to defend. We did a bill last year to let physician's assistants do a procedure that 49 other states currently do, and you would have thought the world was ending. I mean, children are going to die, babies are going to burn. No, it's not. I mean, it was an access issue, and it made a lot of sense. And these are difficult fights, and I understand where everyone comes from on them. But we got to have a real conversation about access. We've done a number of pieces of legislation. About half of the 12 or 13 bills we had signed last year were related to health care. There were just some common sense things. You know, if you can open clinics adjacent to emergency rooms, well, now you have a great ability to have someone come into the emergency room who's not an emergency room patient, stabilize them, send them to the clinic, and have that become their new medical home. They're not going to go to a follow-up appointment somewhere else. They only know how to get to the emergency room. But if you send them to that clinic and they get treated in a lower cost setting than the emergency room, and that's where they do their follow-up care, well, now we're actually talking about bringing down emergency room cost, which was fine, except for the fact that the approval and permitting process for hospitals that want to open these was taking years and years and years and years to get through. And this was a hospital in my district that was experiencing this. We did a bill to basically say if you run a hospital, then you clearly have the capacity to run a small clinic. So there's 1 year to grant the permit, and if the permit's not granted, then you're automatically permitted and you can do it. I didn't think the bill had a chance of getting through. I really just did it because I thought it would put pressure and they'd grant the permit, which happened. The bill actually got through and signed into law. So it was good. I mean, these types of things happen. We've done legislation for community clinics as it relates to how they get reimbursed and making that easy because they don't fit the normal corporate practice of medicine scenario. And I'll wrap up because I think our time's about up. But healthcare is, as all of you know, a phenomenally complex issue. It's also one that incites a lot of passion. I think having watched the last year debate that goes on healthcare, both sides of the political spectrum are out of line and wrong with their characterization about what the other side is trying to do. I've never seen more demagoguing on the issue of healthcare than perhaps immigration. And I think at the end of the day, if you will get people in a room that are committed to having a better system, having more people with insurance, having better health outcomes, utilizing technology, you can find a lot of areas of common agreement. It'd be my hope as we go forward that whether folks support it or oppose the federal health care, it's there and it's the law, and California needs to figure out how to best implement it and do it in a way that puts our state in the best possible place. So with that, thank you very, very much for having me join you, and look forward to hearing from my buddy Isidore. So thank you.
Thank you so much, Assemblymember Fletcher. And thanks to everybody for sticking around. We'll get to questions right after this final speech. I'm excited to have a Republican and a Democrat here. I also wanted to say to Assemblymember Fletcher, one of our recommendations is not that everybody who has nose surgery needs to have local anesthetic. That would probably bring down the cost of care, but we're trying to improve quality at the same time. So Assemblymember Isidore Hall, the third, represents California's 52nd Assembly District in Los Angeles. He is Assistant Speaker pro tempore, which is the third highest ranking member of the California State Assembly. He currently serves on the Health Committee and is the chair of the Assembly Select Committee on Child, Adolescent Health and Safety. In his first term, Hall authored notable legislation on many issues, including reducing childhood obesity and diabetes. Both Assemblymember Fletcher and Assemblymember Hall are rising stars in the legislature who are committed to these issues. So thank you so much for coming here, and Assemblymember Hall.
Well, I'm excited to be here today and excited to have the opportunity to once again talk about some very important issues, particularly as it relates to health care in our communities. It's good to see Secretary Belshé here, and I thank you for all the work that you've been doing alongside of me and the governor in crafting some legislation that exactly deals with that issue. And thank you for mentioning AB 1802 that deals with diabetes in schools. You know, my mother told me a long time ago, she said, when you stand, make sure that there's a social and moral cause attached to whatever it is that you do. And as much as it is so that I believe that we have to build a Californian that represents jobs and economic development and stability across the state, is equally as important to make sure that we take care of the economic infrastructure of our community, which in my opinion are kids. And making sure that as we're growing a community, that we're growing a healthy, a better, and a much better California. And we can only do that when we're giving kids alternatives and allowing them to have access to a healthy lifestyle. I authored a bill not long ago, 1802, that dealt with the administration of insulin in schools. As you know, today there aren't any nurses in our schools at all. And my bill would have allowed for those individuals, a parent, to designate a volunteer, a willing volunteer on campus to administer insulin in the absence, and only in the absence of a nurse, and only when there is a volunteer who is willing and able to train to administer insulin to kids in schools. Because as you know, particularly in the lower socioeconomic communities, black and brown students are facing in disproportionate numbers high rates of obesity and diabetes. And it's just sad to know that in America, particularly even in California, when you don't have nurses and you don't have people there on the campuses giving these kids the proper care and addressing their needs, that we're still fighting for that. And 1802 was just that. It was a battle in the battlefield, and I'm quite sure Secretary Belshé has her experiences with that. You know, I fought the nurses, and I also fought the teachers, because they felt as if, parents should not designate individuals on campuses to administer insulin to prevent an emergency of a child that's in the first or second grade who should actually be concentrating on studying, as opposed to whether or not they are able to get their insulin. And they felt that a parent should have to drive an hour away from their respective jobs to go and administer insulin, as opposed to designating an individual there on campus to administer insulin to kids. And that's the challenge that we have today. I understand the needs of nurses in schools. In fact, I'm very disturbed the fact that we do not have nurses in school. We should have nurses in every one of our schools, but the reality is that we don't. And we need an alternative to be able to better protect and secure the lives and the safety of our kids while on campus. Then I authored an exercise bill, which is AB 2705, which is noted in your handouts today. And the Governor Schwarzenegger, is actually the sponsor of the bill. And the bill simply requires students that while you're in PE, physical education, that you move, that you do something. Rigorous activity, at least 50% of the time. And when I presented that bill, I had some people to come up and object and say, I don't support the bill. I said, would you rather me say they need to do it 100% of the time while they're in physical education? Who would think that I have to put forth a bill and the governor has to sponsor a bill, author a bill, that says that students, if you're in physical education, if you're in a PE class, 50% of the time you need to be moving. You need to have some rigorous activity, and the reality is that is the truth. Because unfortunately, and it's only evident by the great numbers of obesity and diabetes cases that we see, that that's not happening. And unfortunately, we have to continue to push the importance of movement, activity, quality health care, access, because lack of movement in schools, lack of access, means healthcare costs will continue to rise. And you all in this room see it every single day. The only way we're going to make sure that we reduce the cost of healthcare is by making sure that we provide kids with access, that we encourage the importance of eating healthy foods, healthy lifestyles, that we encourage rigorous activity in school and out of school, and that we make sure that we provide the reasonable level of education in the household, not just to kids, but to the parents too. Because just as much as a child would want to eat healthy if the parent or the parents or the guardians do not promote that or accept that, then it's for naught. And we have to make sure and do everything we can to promote that agenda. I also am sponsoring a bill, which is a Food Justice Bill 1488, that allows for farmers markets to go into lower socioeconomic communities, so that those communities, like the community I represent, the lower socioeconomic community of Los Angeles County, could afford the opportunity of being able to go and get fresh fruits and vegetables, again, to promote healthy lifestyles. Unfortunately, in some of the communities that I represent, it's very rarely will you see grocery stores or viable, good grocery stores. In fact, what you see oftentimes is hamburger stands, liquor stores, and donut shops. You know, and it's unfortunate, because what it does, it destroys the minds of our youth. It places our kids in great harm, because that's what they eat every single day. That's what they consume every single day. And then the risk factor, again, of obesity plays an important role there. It comes into play. Diabetes certainly comes into play. And then when those kids go to schools, then not only are they affected by obesity or diabetes or the potential of becoming grossly impacted by that, then there's the self-esteem issues that that comes into play while on campuses as well. So there's a whole umbrella of isolated things, but yet consolidated things that take place when we do not provide quality lifestyle or support the quality lifestyle and justice that kids need while on campus and at home. And so I'm happy to be able to put forth bills, in my opinion, that, in my opinion, would make better a California, will make campuses safer and a much healthier California, and particularly for the kids in our community. The President said any man can stand adversity, but to test a man's character, give him power. And see how he used that power. If he used that power to lift up kids or put down kids, to see how he used that power to speak for or against kids, to use that power to promote a positive agenda, or if he used that power to suppress a good agenda. And as long as I'm in the California State Legislature, you know, I want to be remembered for the great work that I do to help save kids in California, to make sure we promote healthy lifestyles, that we're putting forth bills that would make kids feel like they're worth something in California. And so again, I just want to thank New America Foundation for the willingness to allow me, a young poor boy from California, from Compton, California, to come up here and say some good things about kids and the importance of quality health care and quality lifestyles in California. So again, thank you all so much for your time, and continue to support kids in California. Thank you.
Well, again, thanks to everybody for your patience sticking around. For those panelists who can stay after 2 o'clock, we'll probably stick around to extend the question and answer session a little bit. So I just thought that we'd open this up. Also, thanks to Assemblymember Hall, we now have another O food. I think we can add to Cheetos and Doritos donuts. That's got no in it. If you're interested in speaking, just raise your hand, and Claudia will bring around the microphone.
Hi, I have a question about the transparency or exchange of medical records and how that correlates with HIPAA.
So how it correlates with?
Correlates with what? With HIPAA.
Oh.
David, you want to?
Well, as I mentioned, the fifth of the 5 buckets in the federal program is privacy and security. And there's a very elaborate effort on the national level, and also the CalPSAB, the board that operates on these issues in California, to make sure that both regulatory rules and the contracts and agreements that come into place are stronger than what HIPAA provides for. So HIPAA provides kind of a floor, and a lot of the early work is staying within that umbrella, but there's a lot of work going on to make sure that the new systems address the security of the information and protecting people's privacy.
Great. Thanks. Liz?
My name is Ingrid Croissant-Huber. I am a lifelong conservative Republican and also capitalist. But I'm not for our current healthcare system, never have. I'm not here to get rid of private health insurance, of course I'm not. But the only real answer to real healthcare reform is to set up a healthcare fund where every American young or old, working, has to pay in this healthcare fund. And the health insurance premiums we pay right now would be eliminated. We would be paying that into this healthcare fund. And out of that healthcare fund, when we go to the doctor, we can go to any doctor we want to. Not like now, we have to go to the HMO, to the doctor belongs to our HMO. And first of all, I need to say we have the best healthcare system in the world. And another thing, I couldn't care less how they practice healthcare in Europe, Germany, Sweden, or Canada. But I've studied for years how they pay for it. Let's face it, health insurance companies are like any other health insurance, car insurance, life insurance, house insurance. They do absolutely nothing for us. They are in the business of making profits, and I am all for it. But not on the backs of millions of Americans that are suffering. Millions of Americans right now that have lost their jobs, and I'm talking about young families, have no health insurance whatsoever. If their children get sick, they cannot take them to a doctor. And if they get real sick and they have to go, they can lose their house, their life savings, or if there's a very bad illness in the family, they can they're losing their homes, life savings, they're maxing out their credit cards due to high costs of health care. And this has to stop. We have to start to have a healthcare fund. And this government takeover is a buzzword from the health insurance companies. I mean, everybody knows. One more thing, though. The politicians in Washington, all federal workers, the Supreme Court, and retired military, all have this single-payer healthcare funded healthcare paid for by the government. I would call this socialized medicine. What a healthcare fund would not be socialized medicine, and the government wouldn't tell us who to go to, okay? And I want to say one more thing. I am all for retired military who have TRICARE to get their health care. They deserved it. They are fighting for our freedom, and I'm behind them. But the millions and millions of Americans that worked in factories for 40, 50 years, that are paying with their taxes for their health care, they themselves don't have any health care. And that has to stop. And the American people, we are a free country. We should have the choice to stay with the private sector or go with a public single payer. We don't have this, okay?
Yeah, thank you, Ingrid. I've corresponded with you a lot. And I think the point you make is an important one, which is to say, we're still figuring this out. It's not as if we passed healthcare reform and we're no longer going to have to make any decisions. Hopefully, healthcare reform dealt with some of these issues that you're raising, although we could deal with them in another way. But, because I think this is the perfect follow-up to your comment. Well, hey, the whole idea is, listen, if you do well for doing the right thing, then you should be rewarded. And hopefully, healthcare reform and through the recommendations of this task force will align incentives so that what people make profits for is keeping people well. So now I'd like to call on John Graham from the Pacific Research Institute.
Thanks. My question is, Mr. Fletcher, I think, brought up a good point. In Switzerland, where they have long-term insurance contracts, in the exchanges, the term of the contract that the payer contracts in the exchange is going to be 1 year. But I think the experience of Massachusetts shows us it's not even that long term. I mean, Blue Cross Massachusetts just reported the average term of a health insurance policy is 3 months, and Harvard Pilgrim reported similar things. The mandate is not enough to cause people to sign up. They're waiting till they're sick to sign up, and I wonder if the panelists don't anticipate the same will happen, given that the penalty in the federal law is not actually that huge. Aren't we going to have the same problem as they're having in Massachusetts?
Secretary Belcher, did you want to?
Yeah. I think it's a really important two pieces. Number one, the issue of lock-in or duration of coverage. Maybe I haven't gotten to that part of the 2,700-page citation, but does you read the language, John, locks in for no longer than a year?
Like Medicare Advantage.
Yeah. So that's an important question to know, because frankly the idea of a longer duration of enrollment is potentially a very important and powerful tool. It's one of the things to balance relative to consumer choice. But what we know about the lifespan, so to speak, of individuals, their needs, the incentives with plans, something longer than a year, maybe something that policymakers are going to need to look at if it's allowable under federal law. Your larger question, though, is a really important one. It's something we spent a lot of time on in 2007 in terms of how do you create a culture of coverage that really promotes a community norm that coverage is important, it's valued, and it's available and affordable. And it's not just about mandating people to do something, it's about creating a community, creating multiple access points for available, affordable coverage, as well as a community norm that people will be insured. And so if we don't invest in that kind of community infrastructure, if you will, and it is contemplated by federal reform, and the navigator role of the exchange is a part of that, then we're going to have a hard time. I think it's a very important piece, but it's a fair question. Are the penalties strong enough to really bring people in? And so I know we focus a lot on the stick. I hope as a matter of policy we will also focus on the carrot, what we call the culture of coverage, but we are going to have to look hard at the carrot side of it, because if we don't get people, if people don't enroll until they're sick, reform will not be successful.
All right.
My name is Ralph Ochoa. I'm an attorney, and I think it's a question for all of you. There were a number of pivotal, provocative words: resource, quality, size, coverage, etc. But I understand that California, one of the 50 states, has 17,000 physicians shorter than what we ought to have. And those kinds of percentages of the dearth of physicians, doctors, especially primary care physicians, goes across the country. So if we're covering millions of more persons, the numbers change from 20 to 30 to accept millions more. What's the issue of access if you're all covered, but the doctors today are having problems, and that's exacerbated in rural areas and underserved communities?
Sure. I think that's, Steve, do you want to take the first stab at that?
The good news is this is an industry that hasn't changed the fundamental way it does business in 30, 40, 50 years, and it needs to fundamentally change, and this will force us to become much more innovative in developing delivery systems that build on team care and organized delivery systems, and make better use of allied personnel and the electronic mediums and so forth. I can't tell you right now what all that's going to be, but I know that the resource, the particularly in primary care, in 10 years from now, we will not have enough people to take care of the patients unless we re-engineer the way we're delivering care between now and then.
Great. Thanks, Steve. Gil?
Yes, actually, Ralph kind of asked one of my questions, but I have another question related to the political process. And we welcomed the governor's comment last Friday saying that he was prepared to engage in health care reform. And I also welcome the comment from the minority member, Assemblyman Fletcher, about his feeling important that health care reform was important. Yet we have a process that's been geared up with gridlock here in Sacramento, and we have two gubernatorial candidates that are talking about running against health care reform. And since the state is a major partner in the process over the next couple of years, what does that portend for the political process which will lead to important state enabling legislation to complement health care reform?
Yeah, to turn to the panel real quickly, speak as a political scientist. We're going to hear an awful lot less about repealing health care reform as soon as the Republican primary is over. If a Republican candidate wants to win a statewide office in California, they're not going to run on repealing health care reform. And so I was really glad that Assemblyman Fletcher came here and talked about all the positives. And I think that ultimately it's now the law of the land, and we're going to move ahead in that regard. But there are a lot of important choices. Do some of the task force members?
I would just piggyback on that in terms of acknowledging not the future, where we are today. And California has a near-term opportunity to partner or contract with the federal government to bring in $761 million to provide access to medically uninsurable people. That is a bipartisan issue, and there's bipartisan interest. Indeed, Mike Valines is carrying a bill around the high-risk pools. So we are very much committed as administration, working in a bipartisan fashion with legislature to get the legislation we need to allow California to realize the promise associated with the high-risk pool expansion. That's what we need to do absolutely here and now. Some of these other issues, there probably is going to be a much more healthy debate. There may not be a 2/3 vote. To do the high-risk pool, we need a 2/3 vote urgency legislation. There may not be a majority or a 2/3 vote on every element of reform implementation. Those are fair, important policy issues to discuss regardless whoever the governor is in the next year. But this governor is saying there are a series of things we need to be doing now, some of which are urgency, some of which may not be.
And there's sort of a great irony here in that the Republicans that are refusing to set up high-risk pools, the result of that is that the feds come and set up the high-risk pools on their own, right? So instead of it being a state-based pool, sort of led by the state, since they're saying no, then the feds come in and do it, which you'd think would be the exact opposite of what they would want if they were actually committed to federalism. Do we have a question over there?
I guess that being caught between a rock and a hard place. My name is George Pennebaker. I'm a pharmacist, and I've been involved in these issues for many, many years. The thing that concerns me, or that is of interest to me, is I think with respect to resources, healthcare resources, that was addressed just a moment ago. I think that amongst all of the healthcare professionals, we are going to be reallocating ourselves over the next few years as to what we do. Pharmacists can do this and shouldn't be doing that. Nurse practitioners can do this and shouldn't be doing that they're doing now. And we're going to see that reallocation. And I hope that the reforms that are put in effect are reforms that engender that reallocation and encourage that reallocation so that those of us that might be providing free services now get paid for them where they are needed, and those of us that are getting paid for things that we shouldn't be doing stop getting paid for things that we should not be doing.
Yeah, I think absolutely. That was the theory behind federal health care reform, but in a lot of cases it took pretty incremental steps in that area related to pilots and other small programs. So a lot of what we talk about in this report is how do we need to accelerate that here in California, building on our best models to make sure that we get from where we are to where we need to be. Because some of it is going to be expanding capacity for doctors, but we literally cannot make enough doctors quickly enough. We literally can't do it. And therefore, we need to think about the exact issues you address. Do we have other questions? Oh, okay.
Ingrid, you have to be limited to a question.
Sorry, but everybody's against me. I know that.
Not against you, it's just a question.
And I don't know how to talk. I'm sure you noticed that. But anyhow, coming back to doctors in our country, we do have a big shortage. And when you go to hospital, I belong to Kaiser, I notice we have a lot of foreign doctors, wonderful doctors. We are making it so expensive for our young people to become doctors. Doctors that graduate from medical school, they come out with about $500,000 worth in debt. And if we don't change that, we are not going to have a lot of doctors.
Yeah, thank you. Let me ask the panel about medical education, and I think we'll wrap up and we'll have questions for folks that want to come up afterwards.
What? Actually, the thing, I'm not an expert in this, but I've been in the business and field for a long time, and I've always had been troubled by the disconnect between the education system and the delivery system. There's no matchup. Generally speaking, in almost all the other fields, the education system has some connection towards the demands and requirements of the field that they're educating for. And in medicine, that's absolutely not true. So right now, the federal government is funding residency programs throughout the country to produce gastroenterologists and cardiologists and by the boatload, and we're shortage of primary care physicians. That's a fundamental problem. There's a total disconnect. And, it wasn't in the healthcare reform bill, but somewhere along the line, sooner rather than later, we have to address that.
And I'm sorry, one more question.
Hi, I'm Allison Ramey. I'm with the California Primary Care Association. I wanted to address what Ingrid had said, in that there is a lot of reimbursement opportunities for students going through medical school, especially those that commit to working in the medically underserved areas and serving medically underserved populations. So there is an effort to increase and incentivize people going into the primary care. So it's nice that we are seeing that. It's certainly not going to be an immediate answer to the shortages that we see, but there is an effort that's being made. And I know that our organization is in close contact with the UC system to try to improve the work between providers and the schools in trying to incentivize primary care.
Great. Well, thank you so much. I want to thank again the representatives of the Blue Shield of California Foundation who funded this work, and everybody on the task force for joining us, and everybody for sticking around. Thank you so much.